Good morning or afternoon to all of our students, alumni, staff, faculty, community partners, and guests. I am the Senior Associate Dean for the School of Nursing and Health Professions. My name is June Madsen-Clausen. This is truly a significant point in time for our world, a point in which we have all been challenged. It is also an opportunity for transformation from an individual perspective to the perspective of our communities, country, and world. We are in this together. I want to welcome all of you and express my gratitude on behalf of the School of Nursing and Health Professions for your presence, interest, and support. I welcome you to the 2021 Crawford Lecture. While we are separated by physical distance, we are united by the topic that Dr. Miller is bringing to our attention: a radical approach to the mental health workforce. All of us can contribute to address and improve the mental health and substance use disorder crisis our nation has been suffering for a long time. Today's lecture will address how we can meet the needs of those seeking help for mental health and substance use disorders. This will be the beginning of what I hope is a transformative journey. Briefly, please allow me to share with you a bit about Dr. Benjamin Miller. Dr. Miller has a doctorate in clinical psychology from Spalding University in Louisville, Kentucky. He currently serves as the Chief Strategy Officer for Wellbeing Trust, a national foundation committed to advancing the mental, social, and spiritual health of the nation. Prior to joining the Wellbeing Trust, Dr. Miller worked at the Department of Family Medicine at the University of Colorado School of Medicine, where he was the founding director of the Eugene S. Farley Jr. Health Policy Center, and currently remains a senior advisor. He has been a principal investigator on many federal and foundation grants, as well as state contracts related to health and healthcare integration. Dr. Miller has published on enhancing the evidentiary support for integrated care models, increasing the training and education of mental health providers in healthcare settings, and the need to address specific health policy and payment barriers for successful integration. He has been featured in numerous media outlets, including NBC News, USA Today, NPR, PBS NewsHour, and many more. He is currently an adjunct professor in the Department of Psychiatry and Behavioral Sciences at the Stanford School of Medicine, and is a passionate advocate for mental health transformation, working to fight fragmentation and create comprehensive models of care. We are honored to have him here today. Please help me welcome Dr. Benjamin Miller.
Thank you so much for that kind introduction. It is my honor to be this year's Crawford Lecturer. From the beginning of my conversations with Dean Baker, Carolina, I was so excited about the possibilities to address this issue that so many of us care about. The issue that our nation is experiencing day in and day out, some in more serious ways than others. The issue that if we fail to get right, we will never achieve some of our goals for population health. We will continue to fail communities. Yes, mental health is that foundational. It's that important. As was mentioned, I'm a clinical psychologist by training, and some days, depending on the weather and the way the wind blows, I still identify as a clinician. Those days are long gone. I remember the experiences, the hustle and the bustle of my training of being a psychologist working in a fast-paced environment of primary care. I loved it. And the integration theme that you'll hear so much about today was a theme that I grew to embody in my training and pursue passionately in my profession. I saw it as a solution to so many problems. And this was my journey. It was my journey before COVID, doing everything I simply could to integrate care. Through financing, payment, policy, training, you name it, that was my focus. And then COVID hit, and my trip out to San Francisco to see all of you was canceled last year. The world was shut down, and we were forced to rethink so much of everything. On my best days, I saw this as a magic moment, that once in a lifetime to tackle massive problems opportunity that would have never been unearthed or addressed without a huge catalyst. This is not to minimize our failures and the catastrophic loss of life, over 560,000. No, those families and this impact will be felt for generations. But like many of you, and many of you have seen, when we look at the intergenerational impacts here, 40,000 children losing a parent to COVID, these losses, that trauma, it doesn't just go away. But are we prepared for what happens next? Have we thought through what wasn't working enough to be prepared to put forward a new vision for mental health, for our workforce? So let's go back to last summer just for a second. Kaiser Family Foundation, which Wellbeing Trust has a collaboration with on specifically mental health related briefs, put out yet another survey showing that our country was having to confront mental health and that COVID was causing us harm both mentally and physically. And in fact, just out today, new data from Kaiser Family Foundation that shows how worry and stress related to coronavirus is still about half the adults in the survey population, 47%. So we continue to report negative mental health impacts related to stress or worry from the pandemic. 53%, as you can see on the slide, was from July of last year. I remember, as some of you, that there was outrage and frustration that COVID wasn't doing more for mental health. There wasn't a mental health clinician on the task force. We're not hearing them discuss this. Why aren't we making it a priority? And when it was mentioned, it was used as a scapegoat for why we needed to open back up the economy. And I unfortunately have firsthand experience of a White House and an administration, specific leaders who took research that we had done and misrepresented it to argue that we should all just get back out there as normal, work, eat, and play. But yet we all felt something. We could all relate to this idea of mental health, what it was, maybe in more powerful ways than we ever did before. I called it a crisis-tunity. It's a crisis and an opportunity, because it did appear that COVID-19 forced us to examine mental health, what works and what doesn't. And it was an opportunity within the crisis that we needed to make clear mental health should be forefront and integrated in all our responses of a recovery plan if we hope to avoid going back to the way that we were before, which, as I will say and outline, wasn't working for a lot of people. The Commonwealth Fund, another fellow funder, has put out a series of reports that I'll reference some of them throughout, but the slide in front of you shows that we're more willing than other countries to report mental health concerns. Now, this means experiencing stress, anxiety, or sadness, not necessarily reporting it to our clinicians to get help. And if we take a step back from COVID and look at our history, people have been calling out for help for a long time now. Treatment and mental health services have not met the demand or aren't meeting people where they are. And look at the data. In reality, about 1 in 10 people with a substance use disorder receive recommended treatment. And according to the Kaiser Family Foundation, 39% of American adults have delayed accessing healthcare because of concerns about cost. And 4 in 10 adults with insurance say they have trouble affording their deductible. And when we compare ourselves to other countries, nearly half of US adults who experience emotional distress also report being concerned about neighborhood safety or having enough money for housing or food. When you compare that to only 16 to 19% of other countries like the UK, France, and Germany, it's pretty clear that unmet social needs in the US may be more prevalent than in other high-income countries, potentially contributing to the experience of emotional distress. So we knew that there was a chasm. The Institute of Medicine or National Academies, or whichever your generation worked within that institution has told us for decades that despite the major burden that mental health has caused, and despite the fact that most people still don't get care, the issue of mental health seems to be an afterthought. And honestly, prior to COVID, I just really wanted mental health to get more attention. I actually asked our media team to go back and analyze the Democratic primaries. This is something that it's a data point that I think is so novel, because we wanted to see, of the 30 hours that were spent debating things like healthcare and climate, how much time went towards mental health. And when we look at the 1,800 total minutes, 5 minutes went towards mental health and addiction, not even a full percentage point. And this lack of attention in public forums translates to a lack of action in public policy. It translates into a lack of action for our investments, into a lack of action of leadership. And as a policy guy, I kept naively thinking that if only we're able to make the case it's costing us more, policy folks will listen. But study after study after study shows that mental health is costing us all. I remember very early in my academic career, some studies that we were a part of that looked at workplace productivity and how depression was a leading indicator of, why employers are paying so much. And we looked at issues of presenteeism and absenteeism. We've known the cost of comorbid mental health and chronic disease for seemingly decades. But what should really get us all to stand up and pay attention is the fact that we're dying. We're dying at higher rates than other countries. And this is the sad fact that I'll come back to again and again, because these data are from 2015. And this is before COVID. And then COVID hit. It's the match to the gasoline or the gasoline to the fire or whatever your metaphor is. The conditions for an out of control fire were already set way before COVID ever hit. I look back at the op-eds, the TV appearances from over a year ago, and I see me and others pleading for someone to pay attention to mental health because we knew the data and what was possibly coming our way. Traumatic events of many types can cause damage at an individual, a community level, and it can be in direct and indirect ways. Research is so clear that trauma negatively affects our health and well-being. For example, natural disasters, hurricane, earthquakes, man-made disasters like mass violence are consistently associated with subsequent increases in the rates of PTSD, post-traumatic stress disorder, depression, anxiety, substance use problem behavior. Traumatic events in childhood have long-lasting effects. We know this. And in 2020, the COVID-19 pandemic created this new, almost inconceivable height of trauma, grief, stress, and isolation for millions of Americans. After the first deaths in February of 2020, the virus swept across the country, causing this widespread illness that we've all been impacted either directly or indirectly. And the harm from these illnesses extends far beyond the physical morbidities into our own psyche, into the mental health of our nation. This was the front page of the New York Times. It's actually from a website called Vox, but there was a front page of the New York Times that had a chart on unemployment. And if you looked at the bottom of the page, it was the trends since 1967. And at the top of the page, almost near the masthead, you saw where we were with unemployment. You may have seen this. This was one of the first signs that really got me worried. Because if you look at studies and you follow the evidence and you look at some of the economic analyses, you see unemployment as a major risk factor for what we would call a death of despair. For example, in this one particular study, for every 1% increase in unemployment, there's a 3.6% rise in drug overdose deaths, a 7% increase in emergency department visits. Despair for many leads to death, hence the term deaths of despair. And if you're unfamiliar with your term, probably none of you are, you're probably all quite familiar. The economists Ann Case and Angus Deaton recognized these disturbing trends, deaths to drug, alcohol, and suicide. During the 2010s, which is kind of funny to say that now, over 1 million Americans died from alcohol, drug, and suicide. 1 million Americans from a preventable cause. The decade saw persistent increases in alcohol and suicide deaths and exponential waves of overdose deaths from different types of drugs. Some of these trends continued into 2019, including increases in the alcohol-induced and drug-induced death rates, skyrocketing death rates from specific type of drugs, and worsening trends among certain demographic and geographic populations. There were also two notable trends in 2019, the last available data that we were able to receive from the CDC. First, the age-adjusted drug-induced death rate among Blacks surpassed whites after many years of substantially lower rates. As secondly, while only a slight change, the suicide death rate was statistically significantly lower in 2019 compared to 2018, which is a first that we've seen a change like that since 2004, 2005. So 81,000 lives were lost to drug overdose in the last available data from the CDC. Drug-induced deaths increased by 5% in 2019. This driven by a large part by synthetic opioids and psychostimulants. And the available data indicate that 2020 is going to be much worse. As more 2020 provisional drug overdose data become available, I think we're really worried about some of the trends that we're going to see. The most recent data for August 2019 to July 2020 estimates a 24% increase over the prior 12 months of data. This is almost 5 times the increase seen in the official mortality data between 2018 and 2019, and the greatest range of change in provisional data since the collection began in 2015. So we're looking for the rest of the data coming out later this year. In June of last year, the CDC found that 40% of adults were experiencing mental health or substance misuse problems, and 25% of those ages 18 to 24 had thought about suicide. Just let that sink in for a second. 25% of those 18 to 24 had thought about suicide. Individuals and minority groups had been particularly hit hard by the crisis, and their mental health was in jeopardy even before the pandemic began. began. So between 2007 and 2017, the suicide rate for Black youth nearly doubled. And Native American, Alaska Native youth, whose communities have been especially affected by opioid and suicide epidemic, largely due to intergenerational trauma, have the highest rates of major depressive disorder out of any other racial and ethnic group. So if there was ever a time for workforce, my children helped me with this slide, forgive me. If there was ever a time for workforce to be ready and to be available, now is that time. And this, my friends, is the premise for my talk, that in the face of major need, we have not been able to respond as rapidly as we might want, not because we haven't tried or can't, but because the system that surrounds us has maxed us to capacity, and we are unable to be available even in the most timely of manners. The system around us makes the person's experience look a lot more like this. And studies show the wait times for outpatient appointments with a psychiatrist can last up to, can take you over a week, 25 days or much longer. And as I already mentioned, no wonder most people don't get the care they need. But it's not just the availability of appointments, it's the experience too. So we look into why access is so challenging, why we can't get in faster. This is what you see on the slide is a recent congressionally mandated report by HRSA, the Health Resources and Service Administration, that found that some professions, psychiatrists and addiction counselors, were expected to continue to experience shortages between now and 2030, whereas other professions weren't going to be in such a case. It was going to be, they were going to have sufficient numbers, as they said, and in some cases, an oversupply. Now, what I think is really stunning about this is that this was done in 2017, when it was impossible for the authors to predict that a global pandemic was going to strike, crippling our healthcare system and wreaking havoc on our nation's mental health. So I look at things like this and say, wow, we were thinking we were going to have a little bit of a shortage in some places before COVID. I bet you it's a lot worse now. And to be sure, compared to other countries, we are much worse. If you look at where other high income countries are, they have a vastly, not superior, but they have more in terms of quantity workforce. But let's bring it back to the people and where they live and what they experience. 33% of individuals who seek care wait more than a week to access a mental health clinician. 50% drive more than 1 hour round trip for mental health treatment. 50% of US counties have no psychiatrist. And while these statistics are daunting, they focus only on identifying a provider. Once you get into care, you face a whole other challenge and barriers. For example, mental health office visits with a therapist are 5 to 6 times more likely to be out of network compared to a non-mental health office visit. These barriers are often more significant in communities of color, particularly Black communities, and often as a result in more severe mental health issues due to unmet needs. And even high rates of serious psychological distress have been reported among Black communities, especially around the increase in suicide rates, which I've already mentioned to you. So if we were in person, I would throw the slide up and I would pause and I would say, what would you do? Based on all these facts, based on the trends, what do you do? So one of the silver linings for me during the pandemic is that I'm not traveling and I get to spend a lot more time with my kids. We are watching movies now and we're catching up on movies that Dad has never seen, like Aladdin. So just imagine for a second that you had 3 wishes. What would they be? Chances are, if we did a show of hands, one of those wishes somewhere, somehow, would be about the people that we need to help, our workforce. These data that I've been presenting to you have caused me to think a lot more about the problem and the solution. So from here on out, you're going to hear what I think we need to do about mental health in our country if we're serious about changing the trends. A few years ago, I had the pleasure to lead Colorado's application to CMMI for a state innovation model grant. Our thinking was really simple. Let's find a mechanism to integrate more mental health into primary care. And I'll come back to this in just a second. However, we realized almost immediately that we had to address workforce. So a colleague and I, who were co-chairing the Colorado Workforce Work Group, quickly created a back of the napkin taxonomy for workforce. It was basically like what you see on the slide. There's the current workforce, there's the future workforce, and then there's the community. I'm going to talk a lot about 2 of these. And so let me briefly explain. The current workforce are the folks that we train. For those of you that are in training right now, this is you. We need to be preparing the workforce for the future, for the system that we want, not the system that we have. So how do we think about making sure that the future workforce is actually able to be exposed to new models of care that are team-based, that are integrated? The current workforce, which I'll spend a little bit of time on in just a second, how do we make sure that the people that we currently have are in the right places, taking care of the people doing what needs to be done? And then the community, which is where I'll spend the most of my time, I believe is the fundamental difference maker here in this equation. how do we look at the unlicensed or more non-traditional workforce and allow them to really enter into the equation and enhance everyone's capacity? And this thinking has stuck with me. Recently, a colleague and I published a paper looking at providing a framework for the mental health and addiction workforce in the United States. It proposed 3 shifts that need to take place at a clinical, community, individual level to adopt this proposed framework and to achieve what I describe as the goal of population health. Now, the paper focused on laying out the proposed framework, and then it offered specific policy recommendations that we'll talk about in just a second. But this paper has been a driving force in helping offer clarity in my thinking on the issue. And I'm going to focus for the rest of our time on these 2 categories: primary care and mental health services, or really specifically integrating care where people are, and then what we call community-initiated care. So let's talk about the current workforce for just a second. When healthy community conditions, as you see here on the left-hand slide, good coverage, health insurance, and inclusive policies are in place, we can achieve positive outcomes that improve the mental health and well-being of all Americans. But accomplishing this goal requires us to have a comprehensive framework that sees mental health as existing on a continuum that begins in community and extends into healthcare. Because if we're serious about tackling mental health and addiction in our country, we must leverage all the places and spaces that people show up with needs. We can't simply rely only exclusively on the mental health system to get us out of this jam. So the premise of the framework is that we need to bring mental health to where people are. And that's what this is. Think of all the opportunities for engagement in mental health that we have in healthcare. Think about the moments in emergency departments, in primary care, in our prisons, in our schools, in our workplaces. These are the moments that people are oftentimes most open and susceptible to being able to talk about their mental health. But where is mental health? We're usually not there. It's our time to bring care to where people are. Decades of data show us why we need more mental health in primary care. Decades. I literally chose most of my career past to learn from some of the greatest in the primary care mental health space. But yet we still have so few mental health clinicians present in primary care. And many practices in the United States still don't even screen for depression, even though we now pay for it. So are our clinicians even prepared to work in these settings like primary care? Well, this is a paper that's a little dated now, but we published a few years ago because we simply wanted to highlight that when you begin to conceptualize what an integrated team looks like and the role of mental health clinicians, that the range of mental health need in primary care is so vast that if we only focused on a disease, we miss the boat. If we only look at opportunities to address one small diagnostic criteria without taking into account social factors or the multimorbidities, we miss a moment to actually influence positive outcomes for that patient. So what did we do? We created competencies for licensed mental health clinicians and said, you want to go work in primary care? Here's what it looks like to actually work in primary care. Because we know not a lot of people read papers as much as they used to these days, we created YouTube vignettes so that you can see what it looked like in practice. So that we had the paper with all the evidence that backed it, but we also had the videos that you could see to actually know what it looks like. The future workforce, let's go there, because maybe it's the one that we have the most supply of right now, and it's the one that we just don't use. Yesterday, just literally yesterday, there was a survey that came out about college students, how they're doing during the pandemic. You find similar data, increased distress, low uptake of services, but it was this data point that you see here that stands out to me, where most of the college students tend to rely on their friends or their immediate family more than they do anybody else. So when we rely on our friends and our family a lot more than services, maybe it shouldn't be a surprise to us, but rarely are our friends and our family equipped with the skills to know what to do. So let me tell you briefly about my journey to understand community, and it begins with, of all things, beer coasters. In 1967, a report entitled the Folsom Report, which I'm sure many of you are familiar with, was developed by the private National Commission on Community Health Services. And the Folsom Report put forward a series of recommendations, 14 critical areas of concern. I won't go over any of these with you, but I want to tell you the central thesis of the report. It was pretty much this: a community's problem sheds, much like complex contributors to a watershed, bear little relation to its political, municipal, or jurisdictional boundaries, meaning that many of the solutions that a community needs are not pursued or supported by the structure or those making the rules or decisions. So there was a recognition that complex political and administrative structures often hinder problem solving by creating barriers in communication and compromise. So if the community cannot lead in its own solutions, progress may not be as robust as we might like. Now you want to know about the beer slides. Well, this was done with some colleagues in Northeast Colorado, where they wanted to really highlight the importance of medication-assisted treatments. And they couldn't get people to come to the clinics. They couldn't get people to talk about it. So what they did was they created beer coasters and they put them in the feed stores when people would go and buy the feed for their animals. So you could pick up a beer coaster, take it back home, and you're wondering what this is. And then it had everything you needed on the back of that coaster. So around the same time as the Folsom Report, just a few years earlier, actually, John F. Kennedy signed a major piece of legislation, the Community Mental Health Centers Construction Act, that basically called for the deinstitutionalization of mental health to return people to their communities. He did this because the evidence at the time, and remains, that improvement was more likely to occur inside communities defined by hope, healing, and upward mobility than faraway institutions. He had the right idea: get people into communities, surround them with support, and give them a chance to succeed. The problem was that many of these ideas were best based in the best thinking at the time, but never really codified into much policy. So since then, we've had a patchwork quilt of funding mechanisms that never satiated the starving mental health system. And by the end of his term, actually by the end of LBJ's term, who signed the Medicare and Medicaid Program Act in 1967, little did we know that there wasn't going to be a lot of resources that went into supporting mental health. And here we are in 2021, still discussing this. And it's led to problems like the one that you see here in front of you. We've never really created the system that we needed for mental health. Okay, so let's start with the basic premise that we need to redefine mental health care. What do we do? Where do we do it? Who is the person doing it? And how do we sustain, spread, and support it? I think that this is our bumper sticker for a revolution. Make a note of this, as this is the guide that I feel like we need to embrace. Because in many cases, the what, the where, the who, and the how is not working for people. Because the what might be an intervention that is not needed at the time. The where might be in a clinic that's too far away from my home. The who might be a person that doesn't look like me, doesn't even speak the language that I speak. And the how, that's the policy, that's the administration that's not allowing us to actually get to the place that we want to go. So if the US hasn't gotten it right, where else can we look? And again, the Commonwealth Fund has just been a treasure trove of great work here. And in fact, there are shared traits for international models of mental health. Other countries have embraced strategies that we can begin to adopt a whole lot more in the US. From the integration to seeing social factors as foundational for our mental health, it seems the world does have a lot to teach us. And if you haven't seen the 2017 Lancet Commission report, which was built off the Sustainable Development Goals, it really provided a framework and a grounding for the future direction of global mental health. And I have to tell you, I could do 45 minutes just on this one slide. But I want to highlight three things that are on here that I think are really critical. Number one, the commission called for that we need to meet people where they are. Not to say, how can I get you to me more efficiently, but how do we meet you where you are? Number two, integrate across sectors mental health. And then number three, the last one, democratize knowledge and skills to empower communities. And it's this last piece that these recommendations that have stuck with me. So as a leader in mental health and someone who's helping run a national foundation, I wanted to pursue this democratization of knowledge. I wanted to figure out, what does it look like to create an operational plan that allows us to scale up across the United States, where we have a community that has been well-versed in low-level evidence-based interventions to address mental health and addiction. And when I got into the literature, there's a ton out there, more than we would have time to go through today. Literature after literature after literature showed really creative examples of what happens when you take non-clinicians and train them in certain evidence-based interventional skills. So what happens when you train non-clinicians to do tasks a clinician does? Well, there's a wonderful systematic review or meta-analysis that was done by my colleague Vikram Patel at Harvard that really highlighted the power of what happens when we bring those skills into community and how effective it can be when non-specialists actually represent their community and address the needs of their community. And so introduce you to the idea of task sharing. And many of you are probably familiar with this. Dixon Chabada, a psychiatrist in Zimbabwe, tells a story about losing a patient to suicide. He recognized that he could not be everywhere at once in his country, and he wanted to develop a model that would allow for the people who were there to do something. So he started with grandmothers, the matriarchs of the village. He spent years developing an evidence-based intervention and then studied what happened. In an RCT published in JAMA, Chabanda found that when participants were taught a structured approach to identifying problems and finding workable solutions, outcomes improved. These were lay people simply trained up with new skills. He put a bench in front of a clinic. He put a bench in a village. He put a bench where people were. People came to the bench. The matriarchs intervened. The bench worked. There's such power in this image, power in the simplicity of being there for someone, power in empowering communities, democratizing knowledge, all in service to more proactively impacting mental health. Psychological treatments work. We know this. And across the world, we have the challenge of doing more for mental health. Shekhar Saxena, another colleague at Harvard that I'm working closely with, he's talked a lot about how we have the knowledge and all the technical tools we need to scale up care, but we don't have enough financing mechanisms nationally or internationally. He's spoken so eloquently about how most low to middle income countries spend less than 1% of their total health budget on mental health. In high income countries like us, just around 4 to 5%, which makes you wonder why. Policymakers should ask not whether they can afford not to invest in mental health, but can they afford to actually not to invest in mental health? They're playing with the human capital of their country and their communities. So as I wrap up here, I want to take a deep breath and let's just have a moment together. So what am I really saying here? One, maybe we need to think differently about workforce. Two, maybe our clinical role, the role that we all inhabit, is less important than we thought. Or maybe there's a major place for us to help empower communities using our clinical role and train them up at a broad scale to start to tackle some of these issues in their own way, using these low evidence-based interventions. There will always be a role for specialty care. There will always be a role for clinics and clinicians, but we simply can't meet the demand unless we do something radical. So how do we make this change? I want to give you 4 things. Number 1, if we're serious about population health as our goal, we should pursue any and all strategies for that to be our reality. I believe that I've outlined one of those today, that by going into community, by training community, you not only are able to address issues around disparity, you're not only able to address issues around isolation and loneliness, you're able to address at the heart of what we need to heal, which is other people, relationships. And we're more likely to heal in an encounter of someone that looks like us, that understands our context, than we are with someone who doesn't. Now, that's not to take away at all from the clinical enterprise. It's simply to say that some of the healing that needs to occur in our nation has very little to do with the diagnosis. Number 2, while we work towards this goal, we need to establish the conditions, the groundwork for a newly redesigned system. This begins with our trainees, students, residents, wherever. Let's start to prepare them for the system that we want, as I said, not the system that we have. This means that they need to be prepared for embracing the concept of teams from the get-go, of new and novel settings in which to operate. And as we do this, we must begin to examine our own institution's role in maintaining the status quo. How can we disrupt ourselves? How can we challenge ourselves to do more to pursue a community-forward strategy? One that places the solutions at the center of any of our redesign. And finally, remember, I'm a policy guy, so I got to say this, we must reevaluate policies and practices that limit our impact on mental health. Our collective failure to learn from ineffective policies and programs, and specifically to prune or to cut away the things that are not succeeding, has become a major impediment to improving our health. It leads to wasted time, potential harm, and the loss of faith in policy-making process. In the mental health world, we have so many things that don't work. We limit where a person can get access to care. We have different rules and policies for mental health coverage, financing, and delivery, and so much more. And yet, despite our poor outcomes, we don't question enough or disband our approaches, in large part because we keep perpetuating a system that's dependent on them. I am obsessed with some of the writing of Jane McElvey, someone who understands the differences in organizing versus mobilizing. And here's my take. We need to bring more people under our tent to make mental health everyone's issue, not just to some. In doing so, we have a new constituency, one that can not only be equipped with new skills, but can lead a revolution for mental health. Mobilizing is what happens when you've already organized. We have not organized, my friends. We still need to go out to work across sectors, to work across departments, to work across communities, and find ways that we can organize a new constituency for addressing mental health. So now it's back to you. Our future. COVID-19 pandemic has enveloped the world and created additional stressors to our already devastating situation. As I've outlined, emerging data indicates that Americans are struggling We're struggling with higher rates of distress, substance use, and drug overdose in the past year than we have before. Without urgent action, these issues are already on a grim trajectory. They may continue to be heightened in coming years. This is on us. What will we do? We all need support in coping, all of us, each of us, healing from the pandemic's harm, and we need it now. So to accomplish this, we need to look back at our communities. We need help managing these emerging crises. We need ways to better address the underlying social and economic conditions that support and bolster health, well-being, and resilience. To accomplish this, however, we need a new workforce. We need all of you, of course, and we need you to be in the places that people are. But we also need you to lead, to prepare our communities to manage some of these issues themselves. The difference you will make can be multiplied by helping train up our communities in mental health interventions and skills. It works, but at its core, it's fundamentally disruptive. To move care away from caregivers and clinics and to enable a new workforce that emerges in community, by community, for community. Thank you.
Thank you, Dr. Miller. What a powerful presentation. I hope all participants gained significant reflection points to draw from and begin a transformative journey around these critical issues. I'm going to be your Q&A moderator. So some folks have already submitted questions to the Q&A function. Feel free to submit them if you haven't already. I'll be monitoring those and presenting them to guide our continued conversation with Dr. Miller. We have about another 15 minutes or so for the Q&A portion. Dr. Miller, the first question I'm going to read off from our Q&A is this. I'm a nurse, but not a mental health expert. Can I contribute to
You broke up a little bit, but I'm going to read the question. I think I can get back to you on that. So my first thing I would say is that, as I mentioned and outlined, I believe fundamentally that all of us understand what mental health is. Even if you're not an expert, you can describe your own feelings, your own emotions. Part of the rapport building process that we have with our patients is empathy and able to express ourselves and how we are. Now, as clinicians, sometimes we put up very strong boundaries and we don't want to be overly emotional in an encounter. We don't want to say too much, but I actually believe that there's power in modeling that it's okay to not be okay. I think that there's power in modeling to your colleagues, to your friends, the people that are working side by side with you in your clinics every day that you might have had a tough day. I think that there's power there, and that the language that we use, not only to talk to each other, but the language we use to talk to our patients begins to change the culture around mental health. That's number one. Number two, this is a really simple one that you can do. And it actually goes back to you and your own life. When you go home, when you're talking to your friends, your family, when you're sitting at the dinner table with your kids, ask them how they're doing, and then have the hard conversation when things aren't going well. I'm constantly surprised on so many occasions how we as clinicians don't even like to ask the hard questions to ourselves or our families. Now, ironically, we're more prepared for the answers than most people out there. So the second thing is that we actually begin to change another culture, the culture of our home, when we talk about the issues of mental health. And the third is where we show up. So you don't need to be a mental health expert to raise your hand in a meeting, a department meeting, a public forum, and say, how are we addressing the emotional needs of our patients too? It's a simple question. You don't need to know the answer. You don't need to be the expert, but it gets it on the radar of the people who might know the answer or who might know the people who know the answer. As I mentioned throughout this presentation, we do not talk about this enough. And if every one of us walked away today, went home, talked to our families about these issues, showed up at our next meeting and asked the question of what we're doing for mental health, it would be a different Crawford Lecture next year. It would be a different conversation that we would have over the course of the next 12 months because we've changed the paradigm of what's expected for mental health.
Thank you. I'm just going to repeat that question so everybody knows what the question was that Dr. Miller was answering, because my internet is spotty. The question was, I'm a nurse but not a mental health expert. How can I contribute to improving community mental health, especially as we try to recover from the pandemic restrictions? We have a couple of more great questions in the chat. Another one, if there's just one thing that we could do to address mental health in the United States, what would it be?
Well, I feel like I gave that one away just a minute ago, but I'll say it again. I am a fundamental believer in the power of language and simplicity. And that we in healthcare, especially, I think it's because, we go through so much training and we learn so much that we like to make simple things complex at times. And this is actually one that's complex that we need to make simple. That mental health is foundational to our health. It is essential for our overall health and well-being. That we uncouple mental health from mental illness, and we help normalize what mental health actually is in our community. I think that's the one thing. And I said this a lot. I've had the great fortune to get to work on a lot of policy campaigns, presidential campaigns, and the like. And I can tell you that one thing that we always coached the folks running for office to do was to use the language that people use, to talk about hurting and pain, and not just to mean tissue and nerves, to talk about suffering and isolation, and to connect it to the economic disparities, to talk about issues of race, and to talk about issues of injustice. And fundamentally, at the heart of all of that is how we feel, how we process how we feel, and what we do with our emotions. That to me is fundamentally about mental health. So I think the language piece is my number one.
Okay, thank you, Dr. Miller. A couple of questions have come in that are related to self-care for health professionals. I'm going to read them both. The first one is, many workers know how to prevent depression and burnout. The problem, as I see it, is employers are requiring way too many hours from workers, such that workers do not have sufficient time to care for themselves. Other workers must work more than one job to provide for their families. Without addressing these issues, we will continue to need legions of mental health workers. So there's not a question, but that's, I think, a comment that I think the person would like your thoughts on. And then the related question is, I'm a nurse, recently started to battle with PTSD after being assaulted by a patient. I have found that speaking up and asking for help and taking time off is not popular among nurses. How do we promote mental health among our own healthcare providers?
Oh my goodness, both a wonderful comment and a wonderful question. And so first of all, I think that we have, especially in the last year, we've unfortunately painted ourselves into a corner of pointing our finger at our caregivers, at our frontline clinicians, and teaching them and saying things like, you just need to be more resilient, or you just need to cope with this better. And I've been on so many panels on caregiver burnout that I have to tell you, I am at risk of probably saying something that will get me in trouble one day. But I think that this is a point in time that we have to look at our system and ask what our system is doing to our clinicians. Not just say, clinicians, you need to pull yourself up by the bootstraps and just get over it, but what can we do to facilitate more positive health and well-being? We all live in a fee-for-service world still, as much as I think we want that to change. And as long as we operate under some of those rules, there will be that push, 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 churn, churn, churn. And I'm very cognizant of that. I'm aware of RVUs. I'm aware of the things that hang over our shoulders. But there's a time and a place for our systems to acknowledge their role in how they are contributing or are assisting in enabling our overall mental health and well-being. So yes, we should provide supports to our clinicians. Yes, we should do peer connections and offer digital tools and apps that allow people to relax and learn meditation and deal with stress, et cetera. But if we don't go upstream and address some of the fundamental problems in the first place, I feel like it's going to continue to plague us. Now, to the question specifically around PTSD and the lack of support, this is not uncommon. And thank you for speaking up. I'm sorry for your experience. I know it must be difficult every day you go to work. People, especially so many frontline clinicians, and if you've experienced traumatic situations and you can relate or empathize with this, you know what I'm talking about. As much as I like to say and put this on a bumper sticker, and I'll wear it proudly on my chest, that it's okay to not be okay, some environments don't really enable that. And they do want you just to get your job done. The irony that I pointed out earlier about employers is that you're actually not going to do a good job at your job. You're not going to be as effective. It's what we would call presenteeism, right? You show up, but you're not really all there. You're not going to be able to give it your best because you're somewhere else. You're processing, you're grieving, you're traumatized. The absenteeism is the easy one. You're just not there. So I think that we have a responsibility to have protocols. We have to have what I would think of as like a mental health day in place. I look up to your north of what the kids did in Oregon when they realized that they could have a sick day without any excuse. They could just call in sick, but they couldn't have a mental health day if they were just having a bad day. Why don't we enable that culture for our frontline clinicians? I know it's hard when you've got patients booked. I know it's hard when there's no backup. I know it's hard when it's just you. But that's where the system has got to figure out a new way to take care of its own. Wellbeing Trust was started by a very large nonprofit health system, Providence Health System. And so we created some caregiver tools, and I feel like they have made a difference, being able to triage our frontline staff to make sure that they are getting the care that they need. But we also recognize that this is a time to be a little bit more lenient and go easy on people, to acknowledge that this is not normal. We wouldn't do this in another part of another work environment. We wouldn't say, oh, you just were assaulted and traumatized, just come to work and be normal. No, that's not going to happen. So we have to be responsive in experiences like that. And I don't have a good answer for you. I'm sorry that's something that you're going through, but I would say that you are not alone. That's processing this out, talking this out as much as you can with your colleagues, and doing everything you can to take care of you is probably the only thing I can offer you at this stage. I'm sorry, but it's a tough situation.
Thank you, Dr. Miller. I think we have time for one more question, and I'm going to read this one, kind of shifting gears a little bit. Asking about our spiritual life as COVID-19 has all but decimated the institution of church and spiritual communities. How impacting is this disruption of our spiritual lives on our mental health?
Oh, wow. We need a full lecture on this one. My goodness, that's a beautiful question, Chad, and thank you for asking it. The function and the utility of congregating is a very important part of worship for many people. And the lack of congregation or coming together does make it difficult for some people to still worship in the ways that they were attuned to or used to. Spirituality and the relationship that you have with a higher being, an entity like that, to me, is the power of what happens when you can actually still engage with others and talk about your faith, talk about your spirituality, but not necessarily really reenact that process of congregating. It's a tough one. I watched my parents deal with this themselves. I've seen it personally, where friends and colleagues who run churches, some of my best friends are pastors of churches, and to see how they've tried to enable the power of community and coming together without actually being able to come together. It's been very difficult. But the one thing I can say about this is that for some, it's actually made their resolve stronger. It's made the power of that community, them long for that, more potent. And so when they do get together and we get the shots in the arms and we're all able to go back and see each other in safe and effective ways, I think you will see a redesigning of even how we think about congregations. I think you'll see a redesign of how we think about congregational worship. I think you'll see a redesign of how we think about the importance of buildings versus places and spaces for people and spirituality.
Thank you, Dr. Miller. And Carolina has let me know that you're able to stay for a few more minutes with us. So I lied before. I'm going to ask you just a couple more questions that actually came in advance of the lecture. When folks registered, they were encouraged to submit questions. And these there were two questions around the topic of the mental health workforce working with police departments and seeking to change policing or being forced to change by funding allocations, and just what your thoughts are around hiring mental health workers to answer police calls, and what kind of training the police should have for mental health and chemical dependency issues.
Well, unfortunately for many communities in the United States, the first response for a mental health crisis is the police. And we know from the data that that is not an effective response. And in many cases, especially for people going through an acute psychiatric crisis, it can lead to death. Many individuals who encounter police that are going through some type of crisis might find themselves incarcerated in the first time that they've had trouble with the law. So yes, we need a different response for mental health crises in our community. What I think is the opportunity on the horizon here, as many of you may know, last year, the FCC approved a new 3-digit number for mental health and suicide prevention, 988. That number will be going live in March of 2022. So right now, many states, including California, are pursuing legislation that would allow for telecom agencies to be billed when there was a call to 988, similar to what happens with 911. The ideal scenario is that those dollars go into building a crisis infrastructure. And this gets me to the question and to my answer, that any crisis response that does not include mental health as some part of the pathway or the provision is likely to be ineffective. That we know that a lot of individuals that are calling 911 that are in some type of crisis are doing so because they don't know who else to call. Some cases, yes, there is violence disruption. Some cases, yes, there is disturbance. But in many cases, people don't know where else to go for help. So imagine if there's a number that allows you to actually call and you get a response of someone who is not a public safety, excuse me, who's someone who's actually trained to diffuse the situations. I do believe that police officers should be trained in crisis intervention, but I do not think that that should be where we stop. I think that that should be a natural part of their training just in general, but I think if we stop there, we're only going to get what we've got right now. And I think we have to continue to think about those alternate pathways for individuals, and embedding mental health clinicians into a police car is one way of doing it. Having your own crisis response team that can go out prior or with a police officer is another thing. We've seen it work very well in Arizona and Oregon. It's worked well all over the country. It's time to rapidly scale those models, because if we don't, the headlines just that bring so much pain and ache to our hearts, I think we're going to continue to see them, and we can't afford that as a nation.
Okay, thank you, Dr. Miller. And I know that you do have another commitment, so we're going to transition to our alumni recognition ceremony, and know that you need to leave us. So I hope everyone will join me in expressing our gratitude to Dr. Miller for joining us today and for challenging our thinking about how we can change the trajectory of mental health and substance use disorders in this country by going deeper into the community to look for solutions that can help as many people as possible. I'm sure this is just the beginning of a transformative journey for all of us. Thank you, Dr. Miller.
Thank you. It's been my honor.
Thanks. I now welcome Associate Dean for Health Professions, Megan O'Banion, to lead us in the Dean's Alumni Recognition. This was a meaningful conversation for me. I hope that it was for all of you as well. And I will turn it over to Dr.
Thank you, Dr. Clausen. Yes, this was extremely meaningful presentation and conversation. I appreciate the questions. So for my portion, we invited all of you to nominate our alumni that we would recognize for their work and contributions to providing education on mental health, social and spiritual health, integrating mental health to the unmet needs of the community, fighting for policies towards a fully integrated approach to mental health, and other efforts to increase mental health in our communities more broadly. The alumni of the School of Nursing and Health Professions community would like to recognize several individuals today. And the first one is Dr. Allison Mayo. Dr. Allison Mayo is a doctor of behavioral health, founder of Behavioral Fitness. Allison has 20 plus years of experience working with inpatient psychiatric service providers, homeless services, addiction treatment centers, integrated healthcare quality and process improvements, and Fortune 100 companies. Dr. Mayo has developed groundbreaking tools, programs, lectures, and workshops based not only on her vast professional experience, but also on her extraordinary journey that started as a curious teen who left her family and everything familiar to find herself. She's also a professor at the University of San Francisco, here with us, a county mental health representative, and the School of Nursing and Health Professions Advisory Alumni Board Chair. She's committed to seeing that our communities become behaviorally fit. Congratulations, Dr. Mayo. Our second recipient is Amy Ma, a graduate of the Master of Public Health and Master of Science in Behavioral Health program. And she actually was featured in the USF story titled, Changing the Narratives to Break Mental Health Stigmas. Amy works with Richmond Area Multi-Services, or RAMS as we all know it by, here in San Francisco. And she currently serves as the program coordinator focused on mental health programming for the Asian community. Congratulations, Amy Ma, and thank you. Our third recipient is Danielle, aka Cricket Miller. Danielle has worked with people experiencing homelessness since her graduation from the Master of Science in Behavioral Health program in 2016. She was program director for the Back on Your Feet running program for people experiencing homelessness. And she is beginning a new position as the Rapid Rehousing Program Manager with the Department of Homelessness and Supportive Housing in the City and County of San Francisco. Thank you for everything and congratulations, Danielle. And lastly, but certainly not least, we have Megan Fallon, a graduate of the MSBH, a Master of Science in Behavioral Health program in 2016. She has worked with homeless services in the city of San Francisco. Megan is currently the director for the Embarcadero Navigation Center and the director of the site for a COVID shelter with the 5 Keys School and programs. Thank you so much and congratulations, Megan. I'll turn it back over to Dr. Clausen.
Thank you, Dr. O'Banion. Please join me and Dr. O'Banion and Carolina in congratulating Allison, Amy, Danielle, and Megan, who are exemplary alumni transforming healthcare. We hope you've all enjoyed this program and gained insights for you and your community. We will be sending you an evaluation form, and for those requesting contact hours, you will receive the certificate as soon as you respond to the evaluation. Additionally, you will also receive a follow-up message with curated resources by Claire Sharifi, our wonderful reference librarian and liaison to the School of Nursing and Health Professions and the Department of Kinesiology. She works at the Gleason Library and Jeshki Learning Center to continue your education on this topic. Please stay in touch with us by sending us updates on what you're doing so that we can share them with the community. And please also let us know if you would like to be a guest speaker, an alumni ambassador, a clinical instructor, or a member of our alumni advisory board. We want to continue building community and impacting students' learning and outcomes along with you. We wish you all health and wellness. Thank you.